One.
Good afternoon and welcome everybody. I'm Paul Jensen, Director of Policy and Strategy at the International Union Against Tuberculosis and Lung Disease, also known as the Union. Welcome to this official press conference that will showcase the week's tuberculosis scientific highlights. I think the conference got off to a strong start yesterday. I thought the opening ceremony was powerful and moving, and we're grateful to have so many of the world's leading voices on lung health and infectious diseases with us this week. My colleague, Dr. Grania Brigden, she remarked yesterday that our aim is for the Union World Conference is more than 4,000 delegates to come away this week energized, both with hope and with solutions to some of the most urgent challenges that the world is facing right now. And I think today's press conference does just that. While a lot of the scientific community is of course focused on COVID-19 right now, we can't forget that there are some truly significant scientific advances happening on the TB front. And today we'll hear about some of that progress. Before introducing our esteemed guests, I first just need to briefly run through some housekeeping. This live press conference is being recorded and will be available on the conference YouTube page shortly after we end. Today, we will be hearing brief remarks from our speakers, and then I'll open up the floor for questions from our media representatives attending today. To ask a question, please send it through the question and answer function at the bottom of your screen, and then please indicate your media outlet and who you would like to direct the question to. And then we'll make sure that we direct the question to the nominated panelist. If you do need to ask a question verbally, just please indicate that too, and we can turn on your microphone. Please also keep your questions brief. Okay, with that, let's begin. Our first speaker is Rebecca Berhanu. Rebecca is a postdoctoral fellow at the Department of Global Health in the School of Public Health at Boston University. Rebecca is going to share with us some exciting results of a targeted universal testing trial that has taken place in South Africa. And this, I think, is the first of its kind in that country. Over to you, Rebecca.
Thank you, Paul. Good afternoon, everyone. I think most in this audience will be familiar with the 4-question WHO symptom screen for TB. Every person who presents to a healthcare facility in a high TB burden country should be asked those 4 questions on arrival. Do you have cough, fever, night sweats, and weight loss? And if they answer yes to any one of those 4 questions, they should be directed for TB testing. Global strategies for TB control have largely focused on identifying these symptomatic patients who present to healthcare facilities to identify TB cases in the community. However, there's a growing awareness that symptom-based screening doesn't catch everyone. We know that we miss about 4 to 10% of people with untreated HIV and TB who present to healthcare facilities who do not report a symptom. And potentially up to 2/3 of pregnant women with HIV may not have one of those 4 symptoms, even though they have TB disease. Many of these patients have subclinical TB disease. It's that state of infection that precedes the onset of overt symptomatic active disease. These patients are infectious and detectable by standard TB tests, and yet are not picked up, even though they may be presenting to healthcare facilities for other forms of healthcare. Our study, Targeted Universal Testing for TB, or TUT, was designed to try and find some of these missing cases. So the study assesses the yield of universal testing for TB in 3 high-risk groups in South Africa: people with HIV, people with a close contact with an adult with TB in the past year, or people who've had TB in the preceding 2 years. Participants were recruited in 33 primary healthcare facilities in 3 South African provinces. They were tested for TB irrespective of the presence of symptoms, as long as they had one of those 3 risk factors. 1 single sputum specimen was obtained and split in the laboratory. Half was used for expert ultra and the other half was used for liquid mycobacterial culture. These are the results of our study. Close to 30,000 participants were enrolled. The majority, or 71%, had HIV co-infection, 42% had a close contact with an adult with TB, and 5% had a history of prior TB. We found that 6% of patients in the study had TB detectable by either ultra or culture. The yield ranged from 4.5% in those who reported no symptoms of TB to 10% in those who reported at least one TB symptom. The highest yield was seen in those with a prior history of TB, where 12% had a positive TB test. However, people with TB accounted for the smallest number of TB cases overall in our cohort, as they were only 5% overall. These results add to the mounting evidence that passive case detection based on symptom-based screening alone is not sufficient to identify all cases of TB, even amongst those presenting to healthcare facilities. We also demonstrated that the yield in this setting for universal testing is high when targeted to specific risk groups. For comparison, the yield of ultra testing in the National Testing Program, which is directed at symptomatic people, is between 9 and 10%. So to have a yield of 6% is quite high and striking. Although we saw a very high yield in those with a prior history of TB, and there is some evidence that this group of people targeting this group of people may disrupt TB transmission in a disproportionate way as opposed to other risk groups. We also found that this is a hard risk group to find. They constituted only 5% of our overall cohort. So although the testing yield was high, they didn't contribute to a large number of TB cases found. So I will stop there, and I'm happy to answer any questions at the end.
Great, thank you, Rebecca. Our next speaker is Dr. Susan Dorman. Susan is professor of the Division of Infectious Diseases at the Medical University of South Carolina in the US. Susan will share with us some inspiring results on reducing the length of treatment times for people living with pulmonary TB. Over to you, Susan.
Good afternoon, and thanks so much for the opportunity to share our work today. I'm really pleased to report the news of a safe and effective regimen for shortening TB treatment to just 4 months. For decades, reducing the length of time for treating tuberculosis disease has been a public health goal. And currently, patients with tuberculosis typically stay on treatment for at least 6 months in order to be cured. Shortening treatment can benefit people with TB, their families, as well as our health systems. I'll describe the organization and the key findings of what we call Study 31, A5349. This phase 3 clinical trial was a collaboration between the US Centers for Disease Control and Prevention Tuberculosis Trials Consortium and the National Institutes of Health AIDS Clinical Trials Group. Study 31, A5349 was a randomized, controlled, non-inferiority trial of new treatments for drug-susceptible pulmonary tuberculosis. The trial examined the efficacy and the safety of treatments that were just 4 months in duration and were built around an antibiotic called rifapentine. Our hypothesis was that a 4-month rifapentine-based regimen would cure tuberculosis as well as the standard 6-month regimen, but with the advantage of being shorter in duration. So what were the treatment regimens used in this clinical trial? The control was the standard WHO recommended 6-month regimen comprised of 4 oral antibiotics. There were 2 investigational 4-month regimens. One 4-month regimen simply used rifapentine in place of rifampin. The other 4-month regimen used rifapentine in place of rifampin and additionally used an antibiotic called moxifloxacin. We enrolled just over 2,500 people in 13 countries in Africa, Asia, South America, and North America. We included adolescents and adults, and people with HIV as well as people without HIV. All participants were carefully monitored while they were on treatment and after they completed treatment. The primary measurement or endpoint of the trial, was the percentage of participants who were cured and remained cured at 12 months after enrollment. The key trial findings are as follows. The 4-month regimen containing both rifapentine and moxifloxacin was as effective as the standard 6-month regimen at curing tuberculosis. The standard 6-month regimen cured 90% of participants, and the 4-month regimen containing both rifapentine and moxifloxacin cured 88% of participants. In statistical language, that 4-month regimen met the non-inferiority criteria for efficacy. Importantly, that 4-month regimen containing rifapentine and moxifloxacin was as effective as the standard regimen in all of the primary analyses, all of the secondary analyses, all pre-specified patient subgroups, and in all sensitivity analyses. In other words, the results were quite robust, and we have confidence in them. The safety and tolerability of the 4-month regimen containing rifapentine and moxifloxacin was similar to that of the standard 6-month regimen. In summary then, a short regimen containing rifapentine and moxifloxacin can safely and effectively cure tuberculosis in just 4 months. This is the first clinical trial to identify a shorter regimen that works as well as the standard 6-month regimen. Shortening TB treatment can benefit people with tuberculosis, their families, and our health systems. A shorter regimen will enable people with tuberculosis to be cured faster and may reduce treatment costs, improve quality of life, and help more people successfully complete their treatment. Shortening the duration of treatment by 1/3 to now just 4 months is meaningful to people with tuberculosis today, and it's also an important step in our progress to identify ultra-short regimens to cure tuberculosis. In closing, on behalf of the study team, I thank all of the participants and all of the people who contributed to the study. And just as a final administrative note, my comments today reflect my personal views as one of the study leaders, and I do not represent the CDC or the NIH in any official capacity. Thank you, and I look forward to responding to your questions.
Thanks, Susan. Our next speaker is Dr. Kalpana Sriraman. Kalpana is Senior Research Officer with the Foundation for Medical Research in Mumbai, India. Now, this is a really fascinating study. It's all about adapting the PPE masks that we've seen so often in the COVID-19 wards so that they can be used to collect sputum samples for TB diagnosis from children. And this is a process that's otherwise really complicated, but I'll let Kalpana tell us more. Kalpana, over to you.
Thank you, Paul. Thank you for the introduction, and I would like to thank Union for inviting me to be part of this press meeting. And I'm happy to share our work in this Union platform that brings together amazing researchers, policymakers, programmatic people, and civil society. I represent Foundation for Medical Research. It's an organization that's been doing public health and biomedical research on mycobacterial diseases for the last 45 years. And I'm here to talk about our preliminary work on using non-invasive mask-based respiratory sampling for diagnosis of TB in children, which I'll be presenting later in this conference tomorrow in the session New Solutions to Old TB Challenges. So for more details, you could attend that presentation. This is a proof of concept study conducted in a small number of patients at BJ Wadia Hospital for Children in Mumbai. This is a study funded by private donation from an industrialist, Mr. Nadir Kodrich. To set the background, in the last 3 years, one of our major focus has been to study molecular changes in TB bacteria that is expelled by adult pulmonary TB patients. We were mainly interested in understanding the effect of early treatment on bacteria, and it's a study supported by India Health Fund of Tata Trust. In this study, to capture the patient-expelled bacteria, we used N95 masks and layered it to the membrane. We right now use commercially available gelatin membrane, and we asked the patients to wear these masks for about 10 minutes. And by studying the RNA of the TB bacteria that is settled on the membrane, we demonstrated that viable TB bacteria can be detected in all these patient samples. But most strikingly, what we observed was we could detect TB bacteria in patients who could not produce sputum. This sparked our interest and made us turn towards its use in children. who have the greatest difficulty in producing sputum. As you all know, diagnosis of TB in children is a major issue, and sampling is one of the most problematic part of this process. As much as 50% of children cannot produce sputum, and it's much higher if you consider pre-adolescent and younger children. Hence, it's very common for pediatricians to use invasive method like gastric lavage, which is very traumatic for children at the time of sampling. And it's not just for children, it's even for the family, it's very traumatic and stressful. And but it is necessary for the microbiological confirmation. We need to do that. So we need methods that are easy to collect and less stressful. Since the mass method we were working for in adults is non-invasive and easy to collect, we tested this in children with known TB for potential diagnosis. We asked the children to wear these small-sized N95 masks layered with gelatin membrane for about 10 minutes. And in this 10 minutes, we asked the child to either talk, sing, or even tell a story, whatever they would like to do in that 10 minutes, and intermittently cough and take deep breaths. And we then collect these membrane, and we evaluated the membranes by both gene expert as well as RT-PCR. Gene expert, we thought we would do it because it will be then easily adaptable for the existing diagnostic flow. But our results were a little surprising. What we saw was that TB could be detected in 9 out of 10 patients when we did RT-PCR, but only 1 patient when we did gene expert. We initially thought it may be because of sampling processing differences, but realized it's most likely because bacteria harbors more RNA inside the cell than DNA, which could have contributed to this. And this has been observed in other bacteria itself, where RNA has been found to be more sensitive while detecting the bacteria. But what it may also tells us is that it is time probably for us to rethink our strategy. For years, we've been using DNA-based method for diagnosis of TB, but we are all what we are showing here is that it may be possible to detect TB with more sensitively by RNA-based method. Given the huge advancements that have happened in terms of RNA-based diagnostics due to COVID-19, there is an opportunity to ride on this wave and develop sensitive assay for TB. In a nutshell, we've been able to show that mass-based collection of expelled respiratory particles, when combined with RT-PCR, can detect non-invasively pulmonary TB in children. Of course, this is just the beginning, and the method is showing promise, but we are planning to refine and test this in a larger number of patients. Especially, we need to work on the mass design that suits different age groups, and also more diagnostic workflow-friendly assay, so that it can be developed as a routine diagnostic tool that can reach all children with TB equitably. As I mentioned earlier, diagnosis is one of the stressful periods for the family when the child is sick. Our method being non-invasive and easy to perform, this type of sampling will be less intimidating and less stressful to the child and the family. And if you're interested in knowing more about our work on how we have used mass-based sampling for studying TB bacteria, please also look out for my colleague's talk, Dr. Amreen Sheikh, in this conference in TB Science tomorrow. Thank you. Over to you, Paul.
Thanks, Kalpana. All right, I'd now like to introduce our final speaker. Sachin Silva is a doctoral candidate and a fellow at Harvard University. Sachin is going to talk about a groundbreaking study of the economic and the human costs that will arise if we fail to end TB by 2030. Over to you, Sachin. Sachin, do you mind unmuting your microphone?
Sorry.
Thanks. We've all been there. Don't worry about it.
Sorry. Okay, let's try again. Thanks, Paul. Good afternoon. I'm pleased to present our study, which is titled "Assessing the Economic Impact of TB Mortality in 120 Countries." The second component of the second component of the title really gets at the question that we're trying to answer, which is, what if the NTB mortality target, which was originally set to be met in 2030, what if it is not met? What is the economic and human cost of not meeting the target? This study was a collaboration between Harvard University, the University of California in San Francisco, and Imperial College London. There's been broad consensus that realizing the NTB target, there's 2 components to the target. First, to reduce TB deaths by 90% compared to the 2015 rates by 2030, and to reduce TB incidence by 80% as compared to 2015 rates by 2030. There's been broad consensus that both those meeting those targets by 2030 might be difficult. And there's also been broad consensus that achievement by 2045 is a more likely scenario. What we did was we estimated the full income cost should meeting the NTB mortality target specifically be delayed until 2045. By full income, what we mean is the impact on income growth across 120 countries, plus the intrinsic value of life that a person living in each country would associate with reducing mortality risk. And the way we did this is we considered three scenarios. We first considered a scenario where the target is not met, and we considered the time horizon from 2020 to 2050. The scenario where the target is not met, we considered as the business as usual scenario, so nothing changes. And then we considered our optimistic scenario, which is the target is met by 2030. And then we considered the third scenario, the pessimistic scenario, so to speak, which is the target is met by 2045, which we believe is more likely, and now especially more likely in light of COVID-19 and the impact of lockdowns and restorations. So we felt that was a more likely scenario. And then we computed the full income losses corresponding to each of those scenarios. And then we calculated the difference between full income losses between meeting in 2030 and 2045. And we designated this penalty as the cost of inaction, because in a sense, we are not able to meet the target by the expected date. The calculations, I'm not going to get into the details of the calculations, but the calculations are based on what we call cause-eliminated life expectancy and cause-eliminated mortality risk changes that we calculated for each of the three scenarios. And then we associated a monetary value with the changes in cause-eliminated life expectancy losses and the cause-eliminated mortality risk changes. And thereby, we reached the full income value. I'm going to share our results. You can hear more results on Friday when I present. So in the business as usual scenario, which is nothing changes, between 2020 and 2050, should TB mortality decline at an annual percentage rate of 2%, then we estimated that there would be 31.8 million deaths due to TB, and the full income value due to those deaths is US dollars 17.50 trillion from the perspective of 2030. And let me explain that a little bit. So we're calculating the costs over 30 years, but we're estimating, we're looking at the costs from the perspective of 2030, meaning future costs are somewhat reduced when you're looking into the future. We call that discounting. So the discounted cost is 17.5 trillion in 2030. And we also calculated the distribution of these costs by various regions, by various countries. And I'm not going to share some of those details because you can listen to it on Friday. The second scenario is the optimistic scenario, which is if the target is met in 2030. In this case, we estimated that there would be about 8 million TB deaths. Again, assuming that there's a 2% annual decline in TB mortality, so that by 2030, the target is met. The 8 million deaths would correspond to a full income loss of $4.34 trillion. Meeting the NTB target by 2030 as compared to the business as usual scenario, therefore eliminates about 23.8 million TB deaths and about 13.15 trillion in full income losses. Next, we considered the pessimistic scenario, or the more likely scenario in our perspective, which is meeting the NTB target in 2045. If this were the case, we estimated that there would be 13.7 million TB deaths, again, 2% decline, so that the NTB target is met in 2045. And then we calculated that the full income value of those deaths is about 7.3 trillion, which is still less than not meeting the target at all. And we calculated that difference to be about 10.19 trillion compared to that business as usual scenario. So what this means is that the savings from meeting the NTB mortality target in 2030 versus meeting it in 2045, the savings that's foregone is about 2.96 trillion US dollars, which is about 3 trillion US dollars. In terms of TB deaths, about 5.7 million TB deaths. So by delaying not meeting the target until 2045, that's the economic and mortality penalty that the global community would essentially pay. We also calculated the distribution of these costs and deaths by various regions. And we also calculated the distribution of these costs and deaths in people living with HIV, in people in countries that have a high multi-drug resistant TB burden, and that distribution is also available, and I will get into some of those details at the conference on Friday. So those are our key findings, and I also wanted to note there are several key assumptions that went into our study. Full income is essentially, it's a little bit tricky to fully understand what full income means. It's the impact on income growth, plus the intrinsic value that people living in each of the 120 countries place on premature death, not necessarily due to TB, but premature death. And those are our key findings, and I would be happy to take questions during the question and answer session. Thanks.
Excellent, thank you, Sachin. All right, now we are going to open the floor up for questions. So to ask a question, please send it through the question and answer function at the bottom of your screen. Please indicate your media outlet and the person you would like to direct your question to, and then we'll make sure that we direct that question to the right panelist. Also, if you do want to ask your question verbally, then please indicate that too in the chat so that we can turn on your microphone. And then, like I said before, just please keep your questions brief. And with that, let's begin. All right, our first question is for Dr. Susan Dorman. This is coming from Jenny Ravello, a reporter from DevX. And she's asking, this is a two-part question. The first part is she's asking if you can clarify which of the shorter TB treatment regimens in the trial was found to be safe and effective. Was it the one with or the one without moxifloxacin? And then the follow-up piece to that is, what are the next steps that we need to be able to implement that shorter treatment regimen in countries? Thanks.
Thanks so much for that question. To address point number one, it was the rifapentine plus moxifloxacin regimen that was as effective as the 6-month regimen. You're absolutely correct. There was another investigational regimen that contained rifapentine but did not contain moxifloxacin. That regimen was safe and well tolerated, but it was not as effective as the 6-month regimen. To take your second question, which is such an important question of what next, there are a couple of important steps that will be taken principally by guidelines-based committees, including at the World Health Organization and the CDC. And we anticipate that they will consider the findings of this trial in their next sessions in which they consider and develop new guidelines for tuberculosis treatment. And so we look forward to working with those groups to provide appropriate information and et cetera to facilitate their work.
Great, thank you. And our second question, Susan, is also for you. So this is about costs. And the question is if you have any additional information about the cost of the 4-month regimen in comparison to the 6-month standard.
Thanks for that. Also a very important question. So cost considerations really include two important ideas. One is the cost of new medications, for example, rifapentine and moxifloxacin, as well as their supply. For rifapentine-related questions, I would refer you to Sanofi, which is the company that manufactures rifapentine. I know that the WHO has been in communication with Sanofi around pricing of rifapentine as it relates to new treatment regimens for treating latent tuberculosis infection. The other part of the cost equation gets at how much can be saved by reducing the length of treatment. And those costs will be costs potentially saved at the program and TB provider level, and also costs and time saved by participants in terms of their own activities and work and economic activities. So I hope that addresses your question. Thank you.
Great, thanks, Susan. As we give it a minute to see if any other questions come in, Kalpana, maybe you could tell us a little bit more about next steps from your study.
Sure. So as I was talking about, we need to work on the more diagnostic friendly assay as well as the mass design, which we're planning to work on it in the next few months. And then we need to also expand the study. This is a very small number which we have tested. So we'll be expanding this in a larger number of patients, maybe involving multi-site. And we are going to develop it in such a way that, you know, the technology can be just handled by the diagnostic technicians at the site. So that is the plan for the next stage. Yeah.
Great, thanks, Kalpana. Rebecca, a question for you. What can we expect about this type of risk-based testing? Will we see this expanded across South Africa?
I think that's our hope. The results that I presented are half of our total study results. They relate simply to the yield of testing in certain subgroups. The overall study was a cluster randomized trial comparing our intervention to non-intervention facilities where the standard procedures were followed for TB testing, and we are in the process of analyzing those results. And so what we hope to be able to demonstrate is that supplementing symptom-based screening with risk factor-based testing can increase the number of TB cases identified in a healthcare facility when compared to the standard of care. We'll also be analyzing the cost effectiveness of this type of intervention. It does increase the amount of testing done quite significantly. And so there's certainly a strong cost component. The major funder of our study, the two funders, were the Bill and Melinda Gates Foundation, but also the South African National Department of Health. And they have a very strong interest in this type of approach. It's really appealing, I think, to a national TB program because these patients are the low-hanging fruit for TB case finding. Many case finding trials involve going into the community to look for cases, but this simply involves testing people who are already presenting to healthcare facilities. And so it requires less infrastructure, less staff, less intervention. So it is a very, very appealing intervention that could increase TB case finding in our communities.
Excellent. Thank you. Susan, another question for you. This comes from Amy Green, also from South Africa. The question is, the 4-month regimen is as effective as, not worse than, the current regimen, as you said. Could you break that down a little bit in numbers? Do you have the treatment success percentages, perhaps? Are they exactly the same?
Yes, thanks for that. So in thinking about your question, we analyzed the data in several different ways, using a number of different definitions or exploring a number of definitions. But in the main analysis that we did, the 6-month regimen cured 90% of TB patients. the 4-month regimen that contained the rifapentine and moxifloxacin cured 88% of participants. And then the 4-month regimen that contained rifapentine but not moxifloxacin cured 86% of participants. And in our statistical analyses, the cure rate was similar for the rifapentine, moxifloxacin, and the standard regimen, but the cure rate was lower for the rifapentine only regimen. Thank you.
Thanks, Susan. The next question is for you, Sachin. And this question is coming from Lola Hierro from El País in Spain. And the question is, can you please explain a little bit more what you mean by the welfare costs? And what is the meaning of those income losses for citizens?
Yes, that's a very good question, which I wanted to describe a little bit further during my presentation. Full income, in its simplest sense, is the impact on national income growth due to premature mortality due to a disease. That was the original interpretation of full income. But the reason why it's refined as full income is because there's an additive value of living life for individuals in each country. So it's the intrinsic value of life, which we determine actually based on wage risk studies. We look at empirically estimated studies where the trade-off between living life versus wealth is estimated. To answer the question of what it means, for national policymakers, it provides a rather complete picture of what premature mortality amounts to. It's not necessarily like looking at the cost of excess healthcare spending or impact on productivity. It's a more holistic way to look at the impact on income growth. It's augmented income growth. I hope that helps.
Yeah, I think it does. And a follow-up question for you, Sachin.
Yes.
The impact of COVID-19 on the projections that you're making. Can you explain a little bit more about that?
Yes. So when we started this study, this was pre-COVID. So even back then, there was broad consensus that meeting the target by 2030 was difficult. And even then, there was broad consensus that 2045 was a more realistic date. With COVID, I think that assumption is sort of validated. It's even more unlikely that the targets can be met by 2030. Now, we briefly, not necessarily as a part of the full analysis, but in a limited number of countries, we estimated, because it's difficult because we don't have sufficient data to sort of fit and predict the trajectory of TB mortality because of COVID, right? We just don't have enough data for length of time. So we estimated for a limited number of countries, high burden countries, which were presenting separately when we published these findings. And we looked at what happens, for 2 months of lockdown and 2 months of restoration, versus 3 months of lockdown plus 10 months of restoration. So we estimate, for a limited number of countries, and that data should be available in the future. The other point that I wanted to quickly make is that in addition to the full income, we also estimated the impact on life expectancy. If you were to take away the TB deaths, by how much would life expectancy at birth or at the most productive age increase? So that supplements, our results of the full income losses. Thanks.
Thanks, Sachin. That's really, really fascinating. And that's all the time that we have for this press conference. So thank everybody for joining us. If you have any other questions or want to be in touch with any of the people on the panel today, just please approach Michael Kessler from the union's communications team. And with that, I will say thanks again and see you next time.